We're going to talk about spinal cord stimulation. My name is Brett Smith. I'm the district sales manager for Nevro here in Orlando. This is Matt Golden. He's our regional sales director for basically the whole state of Florida. So we'll kind of split this up. We want to make this very interactive. So if you have any questions, please raise your hand. I prefer not to, just read off slides for the time that I'm up here. Outside of Michelle, anybody in their practice use SCS? I know we got a good mix. Anybody familiar? Let's show of hands. Couple? All right, wonderful. So the company that we work for is Nevro. We were recently acquired by Globus Medical. The deal closed back in April of this year. So now we're under the Globus umbrella, but we'll be kind of moving forward acting as their pain arm. But our company for the last 10 years was known as Nevro. So we're going to kind of get into the differences, talk about the literature and the evidence supporting our product, and we're going to kind of talk about spinal cord stim as a whole. So discuss mechanism of action and the differences between the two types of stimulation currently on the market. So Nevro, we are the one comprehensive SCS solution that offers therapeutic versatility for a wide range of patient populations. We are the only company that offers the full range of frequencies and therapies. So from 2 hertz all the way up to 10,000 hertz, we're the only company due to our patents that can offer that whole range. The 3 main competitors are Abbott, Medtronic, and Boston Scientific. They can only play in the 2 to 1200 range, while Nevro can go all the way to 10,000. And everything that's up there, all the different waveforms that are currently on the market, Nevro can do all of them. Our competitors can only operate with a low frequency and multiplex and burst. So these are the different types of stimulation currently on the market. Your dorsal column stimulation is typically your low frequency option. So for people who aren't familiar with spinal cord stim, it's a tingling sensation or paresthesia that's generated by the leads in the battery. The idea behind it is to cover up the pain that the patient's feeling, kind of trick the brain into feeling the tingling, not the pain. The direct neural inhibition is solely Nevro's kind of playground. So what Nevro's doing with our high frequency stimulation is it's quieting the neural activity by directly targeting the dorsal horn. And this only happens once you reach about 5 kilohertz or 5,000 hertz. And then the paired waveforms is something that only Nevro can offer. Oftentimes we'll pair the low frequency or the paresthesia sensation with our high frequency to kind of give the best of both worlds to those patients. So this is a view of the actual waveform that the low frequency stimulators generate. As you can see, there's a 50 and 1,000 hertz waveform. This is traditionally the 2 frequencies that our competitors use. It ranges anywhere from 4 to 100 hertz and can go up to 1,200. It's very well supported with clinical evidence. It's been around for about 40 years. So if you have any familiarity with spinal cord stim, this is traditionally what physicians and physician assistants are trained on. This is solely a paresthesia-based therapy. Now we're going to get into why frequency matters. So over the course of the last 40 years, this is the only evidence that was done. So there hasn't been a whole lot of studies or high-level clinical data
studied for spinal cord stim, and it wasn't until recently, in the last 10 years, when Nevro became a company, that this is really ramped up. Traditionally, there was one study done in about 1991 that solely looked at leg pain with the traditional paresthesia-based therapy. And it wasn't until Nevro came out back in 2014 when we did the SINSA RCT, when new evidence started, coming to the forefront. Sunburst study was done by Abbott. HD and Whisper were done by Boston Scientific. They were utilizing about 1,000 hertz. Burst was also 1,000 hertz. This Kumar study was low frequency 50 hertz therapy. Over here, these are the Nevro studies. So as you can see, the pain relief was far superior than any of these traditional studies. And this second one here was our low frequency arm or traditional stimulation arm for our SINSA RCT. We'll get into that later. But we really start seeing neural inhibition around 5,000 hertz, and it maximizes at 10,000 hertz. Before we get any further, I wanted to touch on MRI because that's a very key component of these systems. Nevro's system is 100% capable of getting full body MRIs. For the extremity, head and neck is 3T weighted, and then for the trunk is a 1.5 Tesla weighted MRI. So here we'll get into the mechanism of action, why this is working. So for 10,000 hertz therapy, the WDR neurons, they're the neurons most implicated in chronic pain. And with 10,000 hertz therapy, what it's doing is it's driving the inhibitory response while minimizing the excitatory response. So for traditional spinal cord stim, it's a high excitatory response. That's why it produces the paresthesia sensation, and less of an inhibitory response. And then you can see in this graph here, the higher the frequency, the more inhibitory neurons are brought into play. And that's really what you're looking for here. So as you can see, the 10,000 hertz therapy, extremely high inhibitory response, very low excitatory response. This gate control theory, this is the theory that traditional spinal cord stimulation was based on. You apply a non-painful stimulus to the whatever nerves are causing the chronic pain. It kind of tricks the brain into feeling the paresthesia or the tingling response, and the patient doesn't feel the pain. There's a few drawbacks to this, and we're going to get into that. And this is one of the main ones. So paresthesia coverage with low frequency stimulation means better pain relief. So you really want the paresthesia to cover the pain area, and that's when you will get the most pain relief. So if you can look at this graph here, it shows that, with all these data points, the higher percentage of relief means the more coverage, and vice versa. So that's really the drawback, and the way that the low frequency does work. It's a drawback because if you're getting coverage in the foot and the pain's in the leg, you're not going to get pain relief. So over the years, this has changed quite a bit, and the reason is because of the high frequency therapy that was brought forth by Nevro. So for traditional SCS lead placement, you place it where the pain is. So to get better coverage, you got to place them directly on the level that's providing the pain. And during the procedure, it's more so for the trial procedure, but they'll wake the patient up, produce the paresthesia. The patient agrees in intra-op that, hey, it's covering where my pain is, then they'll finish up the procedure. If it doesn't, they have to move the leads around, try to get coverage in that pain area in order to get the pain relief. So the procedure times can vary, and most of the time run longer than expected due to this. With HF10 therapy or 10 kilohertz therapy, we place our leads anatomically. So every back and leg pain patient is going to have their leads at the top of 8, top of 9, and it gives us coverage over this 9-10 disc. Throughout our research, we found that For back and leg pain, really the sweet spot for most of our patients is that 910 disc. And if it's not on the disc, it might be slightly in the T9, slightly in the T10, but it's in this general area. So that's why we always place our leads here. Nice thing about that, there's no paresthesia mapping, no waking the patient up, patient's comfortable throughout the whole procedure. We place the leads anatomically, speeds up the case time, and it's very predictable. So to further emphasize that point, leads are placed anatomically. It's completely paresthesia independent, meaning you don't have to place the leads where you need coverage. So again, we target that 910 disc, and that's where the pain circuit neurons for low back and leg pain are typically located. And 10,000 hertz applies directly to those pain neurons located in that area, which in turn gives pain relief. So this was an analysis of patients from our Senza RCT, which was our study that we used for FDA approval. So this is an analysis of those patients, and we found that the higher the frequency, the more pain relief they got. And you didn't really start seeing that neural inhibition until you reach about the 5,000 hertz frequency. And Matt's going to come up and go over the evidence. Okay.
All right, thanks, Brett. So I'm going to go now into some of the clinical evidence and a little backstory on this. A lot of the things Brett just went through on why Nevro was different than anything else on the market when we came out. I think we got FDA approval in early 2015, is the fact that it is 10,000 kilohertz, and nothing like that's been done before. So in the past, Medtronic came out to market first in the 1990s with their device, and then Boston Scientific and Abbott followed, and they just got approval based on a single study that Medtronic had from the mid-90s. And that was okay with medical devices. You could say, hey, it's a spinal cord stimulator. It's the same as his, and just piggyback off of that data, and that's how you get approval. With our therapy being different, the FDA came to us and said, look, we've never had a 10,000 kilohertz device before. You need to prove that it works, and you need to prove that it's safe. So we had to undergo a massive RCT, which we did, and use that to ultimately get approval here in the United States. And that really kind of built the foundation for us being the clinical efficacy and clinical study company. We've got more RCTs than everybody else combined. We've brought more indications, which we'll get into, and we've really changed the way that the market looks at clinical data and studies. So this kind of shows the big three that we have. You can see on the far left, the Senza RCT. That was the first study, and that was the one that we used to get approval with the FDA. And in that study, we did a complete head-to-head with the market leader at the time, which was Boston Scientific. So we had the Boston Scientific arm and the Nevro arm. And Nevro and spinal cord stim was their RCT done. That was a true head-to-head until this. And I'll get into the outcomes of that here in a little bit. And then we also had two more big ones that, since we came to market, have got us indications for patients with painful diabetic neuropathy, and then also patients that aren't candidates for back surgery. And we'll get into those too. Okay, so here we go. This kind of looks at those three big studies. You can see on the far left, that was the Senza RCT. 76% of patients responded. This is at 2 years. That's the other thing. All these studies run for 24 months. You can see in the middle, non-surgical back pain. And I'll get into more details on that too, but 82% responder rate at 2 years. And then PDN, which was brand new to this therapy, 90% responder rate at 24 months. So we'll get into more details on that as well. Okay, looking back at responder rates and rescue studies. So another thing we wanted to look at is, okay, since this therapy is different, there's nothing else out there, how would patients respond that used to have an older stimulator that stopped getting relief? So these are patients that were implanted with a competitive system, whether it's Medtronic, Boston, or Abbott, low frequency, like Brett talked about. These are low frequency stimulators. And what happens if we just take the IPG off and hook up a Nevro system. And you can see that 81% of those patients got pain relief back in using our therapy, which just goes to support, again, that is a completely different waveform, different mechanism of action. And it's given a lot of providers the opportunity to take a therapy that's failed, that's not working anymore, and giving those patients an alternative. And in this study, this just proves that the majority of those folks do really well. 90% of them received at least 30% pain relief coming from a failed therapy. Okay, looking at real world data compared to the Senza RCT, which is that first study, you can see that the therapy is robust, and that what we saw in that initial study, we continue to see in our real world data. And it all kind of falls in that same line. Okay, looking at the evidence across the board, we have studies in all kinds of areas where typically what we treat is mostly low back and leg. That makes up most of our patients. We'll do cervical implants from time to time. We have a really good 12-month cervical study that's out there. Diabetic neuropathy is, like I said, the other one that we recently got. We treat chronic leg pain, pelvic pain. We do see some abdominal pain. So our therapy can be used to treat all kinds of things outside of just low back and leg. Any questions so far over any of this? Yes. Mm-hmm. Perfect. Great question. So for us, our target area is C2, 3, and 4. So we want to get the top of the paddle. We tell you to get it up as high as you could, like top of C3, lower C2. Yep. Yep. We've got a thin little paddle. It's called the Surpass C, and it's the lowest profile, it's the thinnest one on the market, and it's designed for that exact purpose because it's a tighter space. Yeah, we just don't see as many of the. We do a fair amount. Maybe 10% of what we do is cervical placement. What's great about this therapy is the challenge with a paresthesia-based therapy up here is if a patient has that and does this or does that, the stimulation is completely different. With ours being paresthesia-free, they don't experience any variability, and they love it, and it works. To me, it's the most effective place. Yeah. Yeah.
That's greater than 50.
Mm-hmm.
And it falls in line to, he's going to go over the, but one of the things we saw in PD symptoms also went away.
Yeah. 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 It works really well. Any other questions? Okay. So now we'll get in a little bit to the Senza RCT. This was the original one. Like I mentioned, it was the first true head-to-head. There's been some other head-to-head since, but it was always one company going against one of their older devices. So Medtronic has one, but it's Medtronic folks doing both arms. And this one, the Boston Scientific arm had Boston Scientific engineers and reps programming those patients, seeing those post-ops, seeing those reprogrammings in the clinic. And the Nevro arm had Nevro. So it was truly one company testing the device against the other. And you can see that at 24 months, 76% of patients got good back pain relief. And that was the other thing about this. Before this study, every previous RCT was looking at just leg pain. This was the first attempt to truly look at the low back, because in our business, that's always been one of the more difficult areas to get pain relief with the stimulator. Back was always a challenge. Leg pain was fairly easy, but back was tough. And this was one that looked at, okay, how do these patients respond in leg pain, and separately, how do they do with back pain? And you can see here that for back pain, they did really well. Leg as well, but the back is what stood out to us. Looking at the patients that were enrolled, these are patients that had at least a 5 out of 10 on their pain scale for both back and for leg. And then they also, on the ODI, had 41 to 80 out of 100 on that score. So these are patients that had significant pain. one too far. Okay, just one more point about 24 months, 76% responder rate. The only one that's paresthesia free. This actually in Neurosurgery Journal got Pain Paper of the Year when we published this. So we're very proud about that. This shows that it's durable for 24 months. You can see patients responded quick, and that pain relief was sustained throughout the 24 months. The lower light blue line is Nevro's patient responder rate. The other line is Boston Scientific. So you can see there's a significant difference between how patients responded in the two arms. And then there's the chart for leg pain relief. Same type of drop, same kind of difference in responder rate. All right. The other RCT, the second one we're going to talk about is patients with non-surgical back pain. So these are folks that have back pain, but they've seen a surgeon. Part of the inclusion criteria is they have to have an MRI, see a surgeon, and that surgeon has said, okay, there's nothing I can do to help you. Like, you're not a surgical candidate. For whatever reason, they get eliminated from that, and that was what they had to do to get enrolled in the study. So these are truly patients that don't have a surgical option. What are we going to do with their pain? And this was the first study of this type to come out. And where this has been really good is it's helped us get these approved by insurance companies. We use this all the time. If an insurance company denies it, we can send this in with notes from a surgeon saying, hey, this person saw a neurosurgeon. He or she said, you're not a surgical candidate. And we use these to get a lot of patients access to the therapy. So this was a big study for the whole industry and for your patients. I just talked about a lot of this. No previous spine surgery. They had to be refractory to conventional treatments. Back pain of at least 5 out of 10 eliminated as a candidate from surgery. And it was basically the SCS arm with conventional medical management versus conventional medical management alone. And you can see here, these are the patients that were implanted over 24 months. Same type of pain relief that we saw in the first RCT I went over. So you can expect that whether these patients have had back surgery or not, you can expect the same type of pain relief, durable pain relief over a 24-month period. And this looks at individual patients. We call it a tornado chart. You can see that the majority of these patients, 82%, get over 50% pain relief, but over half these patients are getting over 80% of their pain taken away with this device. So that's a profound response. And we see that a lot, you know, when we're programming and see these folks in the clinics, that they do really well. And that's the non-surgical back study. This was one of the biggest studies in the space because prior to this, we knew that spinal cord stim worked good for patients with neuropathy. But patients with diabetes that have painful neuropathy, it's a massive market. They tell us that there's more of these patients than patients with back pain, which is crazy to think about. Before this study was done, because this was the first study done, first RCT done with this type of patient, only about 6% of the patients nationwide had coverage for this indication. This was considered off-label. Now, this is 4 years post, 81% of patients across the country now have access to a stimulator that have this indication. So our study has really changed the payer landscape, and it's given physicians and providers a great option for these folks, because with this pain, it's, you know, they're not surgical candidates. About half of them respond to gabapentin or some kind of oral medication, and then half of them don't. And what do? You can't operate on them. There's really no options for them. So this is, what's that? Yeah, well, I mean, lifestyle changes. But there's a lot of these folks out there that this has become a really, really good option for them. It was because of this. This was really the game changer, the study that we did. So this RCT went again for 24 months. It was the biggest one, the only one at the time that was of this size, over 18 centers. And we continued to follow these folks for 2 years. At 6 months, we did have an option to let patients cross over into the treatment arm, and you'll see some of those responses when I get to the next few slides as well. And yeah, 93% of those folks did cross over. This kind of goes down to the breakdown of the trial and the implant. And I don't know if we talked about trials yet, but I'll take a minute to mention that. Before any of these devices, for those of you that don't know much about the therapy or don't have exposure to it in your practice, Before any of these devices are implanted, the patient goes through a 5 to 7 day trial. Implanted medical device, so we didn't see any rise in infections. One of the criteria was 10. A1C 10, I believe, at 10%, yeah. So we didn't see an increase in infections that we wouldn't expect to see in a normal patient population. So this looks at the first 6 months before the crossover, top line being conventional medical management. That's what you'd expect. These patients weren't responding. And then you can see with the 10,000 Hz therapy, that patients got incredibly good relief. 76% reduction. And then you can see here, the yellow line is the patients that did the crossover, that joined, and they got the same response that the original patients did for the study. Pain scores in the mid 7s down to below 2.0. Here's another one of the tornado charts showing that 90% responders. We actually have a higher responder rate list than we do with back and leg pain. 80% average pain relief, and the number to treat being 1.3, which is really, really low for a therapy like this. So one thing that was unexpected in that study that has now got us to do another RCT that we're about halfway through right now is with these patients, not only did they get relief of pain, these diabetic patients, but they also got improvement in some of their sensory symptoms. We looked at numbness, tingling, burning, and cold sensations. And it was such a good response. It was over 60% of the patients saw an improvement there that we stood back and said, this is something we need to look at further. So now we have a large RCT going on right now, looking at just sensory symptoms, because if we can show that patients also have sustained relief with their other things that bother these folks, numbness, tingling, that's just another thing we can use to help get patients access to the therapy. And the ADA is very interested in this. They have spinal cord stimulation in their treatment algorithm for pain now, which they didn't have prior to this. And if we can show improvement in neurological symptoms, that's going to help there as well. Sleep is another thing with these diabetic folks. They'll talk about what they tell Brett and I when we're seeing them pre-op. They'll say, I can't put the sheets on my feet. I can't sleep at night. We saw a significant improvement in sleep, 66% reduction in disturbances. So we'll see folks that'll say, before they have their trial, we always ask them, what are some things you want to see benefit from? They'll bring up sleep, and we'll ask, how many times you wake up at night because of your pain? A lot of them will say 6, 8, 10 times. They'll come into the lead pool for the trial, and they'll say, I slept through the night last night. I haven't slept through the night in years. So this was another thing we looked at that we saw a massive improvement in. I talked earlier about the number to treat, and at the 12 months data for this, 1.3. So very few people who get this therapy in their hands don't respond. So you can feel comfortable that they're going to do well. And then last, I'm just going to go through a few slides on our newest device, which is, we call it Adaptive AI. It's the first device in this treatment with AI technology. Some of the things Brett talked about earlier about how our lead placement is standardized. All of our programming follows an algorithm. So whether a patient is in Orlando or in Seattle, they're going to get the same programs. It's just the way that our therapy works. There's very little variability in what we're delivering to the patient. So since we came to market, we've tracked every patient that's been implanted. It's a lot of work on our part, but every time we talk to a patient, we have a cloud that we'll enter. We'll say, Betty Smith, and we'll log a pain score. We'll log the electrodes that we're using to stimulate that patient. We'll log the amplitude that patient is running. And all that data has been collected since we came to market. It's actually collected in Europe and Australia years before we were here in the United States, for 14 years. So we have 100 million data points of how patients have responded to different settings. So we took all that information and developed this adaptive AI system where now the patient can, I'll get into this in a second, they can put some input into their app, and the system will automatically make adjustments based on how that patient's doing. it's really exciting, and we've had great outcomes. And all this is built on that data we went through for low back, leg, non-surgical back, PDN. When we implant the patient, we'll put into the system what their pain is, whether it's PDN or back and leg, and then the system will know what algorithm to work them through. And you can see here some of the improvements in sleep, decrease in medication, close to 90%. Who doesn't want to see that? That's great for us to see. Function improves. Patients are very satisfied with the therapy. And it's all based on an app. So they'll get asked some questions. I think that's on, Yep. They'll get asked some questions on how they're responding. Are they sleeping better? Has their pain medicine changed? Has their activity changed? And based on what they're putting in, the system will either keep them where they're at. If they're doing well, then it won't change anything. If it looks like they could benefit from a small adjustment, the system will tell them on their app, say, hey, we think you need an adjustment. Do you want to do that? Patient will hit accept, and it'll make the change. So this has done a few things. It's one, it's given these patients for the first time ever the ability to give feedback on their pain relief and have a system that automatically in real time makes an adjustment. It also makes these patients feel like they have some control over what they're doing. And we know that that also helps benefit. And what we're also doing now, and I think at Orlando Health we do this with the pain group, is the providers now can log into a portal and see how all their patients are doing. So they can see what their pain relief is. They don't have to rely on calling the rep to say, hey, how's this patient doing? They can log in and see exactly what the patient is putting in. And it gives good transparency, and it allows the providers to keep an eye on how their patients are doing that get these devices implanted. I think that's it.
That's it.
Any questions? But I think, yes.
You mentioned about the provider portal. Can the providers make changes to the device based on patient input? Like you were in clinic and the patient was telling you how they were doing?
No, they
You go into the
can't.
portal and change it?
Yeah, the providers can't make changes.
Yeah, it would go through the patient's app. So if there's anything that you would want to recommend to them, they can start doing it differently within the app. But the input on the app is what makes the changes to the device.
Yeah. Every time they upload an assessment, the device will decide, hey, do we need to leave them or make an adjustment? And it can be, the other good thing is the device is aware of how they responded on every previous setting. So if a patient is kind of flatlined and not improving the relief, the device will look back and pick another program that they responded to and combine those two and run them together in an effort to get a little bit more relief. So it does a lot of cool things to try to get these folks the best opportunity to respond. Yeah. And it's been great so far. Yes.
So you said for like, if they failed like prior therapy with a competitor device, you just need to change out the actual device and not the wires. Do they still have to go through that trial period?
They do not. They do not. You could either change the whole system out, or you could just change the IPG. We see both, and it depends on what the doctor seeing, whatever the physician or provider thinks is the best for that patient. So it could be either one. We have adapters if we need them, so we don't have to change the wire. But some doctors are like, we'll just change the whole thing over. Yeah, it could be either one.
There's one caveat to that. So depending on where the leads are placed too, it might not be the correct move to leave the current leads in. A lot of our competitors, because of the paresthesia, they're trying to get back pain coverage. So a lot of times they'll place it like T6, T7. So where those leads end might not be close to that 910 disc. And for HFX, for that 10,000 hertz therapy, you really need to be within that ballpark in order to get the correct effect from it. So a lot of times if the leads are too high, some surgeons will try to pull them down, but if that doesn't work, then they'll just pull them out and re-implant. Thank you, everybody.
Thanks.